Welcome everybody. Tonight we have Parker Mackin, who is the Director of GP Synergy New South Wales and ACT Research and Evaluation Unit and Conjoint Professor at the University of Newcastle.
Thank you, Glenn, and thank you to GPSA for inviting me to give this talk, and to the supervisors for coming along. As Glenn said, I'm the Director of the GP Synergy New South Wales and ACT Research and Evaluation Unit. And my background, my craft background is as a GP. I suppose my principal research interests are in consultation, clinical and educational experience of registrars, and outside of my educational work, my main research interests are in medicines use in older people and TIA and minor stroke in the community. So we're going to talk about the Registrar Clinical Encounters in Training, or ReCEnT project, and some of their findings and how they might relate to what supervisors do. So ReCEnT commenced in 2009 with a pilot study, and from 2010 to now in 2021, the main study itself has been going on. And it's a project that incorporates educational research elements, and they're closely aligned and they're interdependent. And we do that within a translational education research model. So our education informs our research, and our research informs our education, and we work closely with MEs and also with other stakeholders in generating research questions, especially registrars and academic registrars and other RTO staff and supervisors, etc. So it was originally conceptualised as a research project, but soon, as I said, morphed into a combined research education project. And now the education tail tends to wag the research dog a bit, but tonight we're going to talk about the research aspects of the study of the project. Now, I'll just let you read that little quotation, and this comes from the most recent, this month's edition of Academic Medicine, which is the highest ranked medical education journal. And the idea that they need to see if American internal medicine trainees are getting adequate exposure, coverage of exposure. Now, that's pretty much exactly the question or the idea that my colleague and friend Simon Morgan came to within 2008. And so that was the original aim as we started planning ReCEnT, was to map the territory of registrar experience. And Simon's term for this was the black box. We didn't know what registrars were doing behind that the door of their consulting room, and so we wanted to find out what was going on, and also to establish association so we could better understand what was going on. And the parallel is in general practice prior to Beach, and at that stage we had no idea what GPs did. You know, we had a profession and we didn't know what we were doing. So we didn't know what our peers did. Was that what we were doing? So similarly, we didn't know what registrars were doing prior to ReCEnT. That was our initial aim, to map that. We also wanted to know what registrars did, and especially did their clinical behaviours align with the evidence and with evidence-based recommendations, and again to establish associations of those behaviours so we could better understand who was doing what in what circumstances and what the influences were. We also wanted to see if registrars' clinical behaviours changed during training. Registrar training is a pretty intensive educational training experience, and we wanted to map how their training, especially their clinical behaviours, changed from term 1 to term 2 to term 3. And that was individual registrars. We also wanted to, later on, as we got data over further years, we decided we would like to look at how behaviours changed over time, not of individual registrars, but the effect of the sum of registrar behaviour. Did it change from one year to the next year, etc. We also were quite keen from the beginning to explore how, as much as we could, how registrars learned within their clinical consultations. And then what seemed like a little bit of a a little bit of a real goal was to see if our education actually changed registrars' clinical behaviours. Now, we're pretty confident we can change registrars' knowledge. We've got plenty of evidence for that. But we wanted to know, could we change registrars' clinical behaviours? And how do we do this? Well, the basic thing is we collect data. And in each of their first three general practice terms, our registrars, around about the middle of the term, our registrars collect details of 60 consecutive office-based consultations. Now, we exclude nursing home visits, which has been largely a logistics decision, but we also exclude specialist clinics, and that includes, say, flu immunisation clinics, COVID immunisation clinics, pap smear clinics. And the reason we exclude those is, I suppose, again, we have to think about what our focus is. Our focus is on how we can enhance training for registrars. And while from a research point of view, it would be very nice to actually have some data on this stuff, especially currently, it'd be nice to know how many COVID vaccinations are being delivered. It's pretty useless to a registrar when their reflective report comes back a couple of weeks after they collect the data, and it just tells them they saw 48 flu clinic immunisations and their mean consultation duration was 3 minutes and they didn't make any referrals. So we have to remember all the time that our focus is on our registrars and their training. And I'd like to be able to say that those registrars are transfixed by one of my recent orientation talks, but in fact that's just from one of our educational workshops, an educational presentation. So this slide, which you can't really read too much, is just to point out that since last year, since 2020, we've been collecting this data electronically online. But to actually get a sense of what we're recording, we'll go back to 2019 and before, when we had hard copy case report forms. And each of these CRFs, one would be completed by a registrar for each of their 60 consultations. Now, this looks pretty complicated and a whole lot of stuff there. And I do want to illustrate to you just how many different parameters we collect. But in fact, in any single consultation, usually most of this is left blank, is left white. And it takes 1 to 2 minutes on average for a registrar to complete each of their forms. The other thing I'd like to show you is just these little numbers here, 1, 2, 3, 4, 1, 2, 3, 4. With those, the registrars actually link the things they do in the consultation back to which problem or which diagnosis they're linked to. So registrars can collect up to 4 problems or diagnoses, and for each of their actions, whether it's prescribing medications, referral to specialists or to wherever, pathology, imaging, each is linked back to one or more of these diagnoses. So that gives us quite flexible and useful data that we can use to really work out what's going on. And also, there's a lot of variables. So again, this complicated table is just to show you that this is one page of a 2-page table in a publication to show you all these variables that we use, and they enable us to do these quite nuanced, fine-grained, multivariable analyses. This one is on the difference between registrars' experience in urban versus regional versus rural practices. But the idea is that we have a lot of variables so we can get really fine-grained understanding of what's going on. So they're the strength of the study, that we have a lot of variables collected, and the variables are linked to the problems that registrars are dealing with. There are significant limitations of our data. The main one is that our data is of a snapshot of the consultation. We don't have a whole lot of other contextual information. We don't have the patient's treatment regimens. We don't have lists of their past illnesses. We only have what's dealt with there in that consultation at that time, what problems were dealt with, what medicines were given, etc. And it's a longitudinal study of registrars. Registrars are the participants, not the patients. So we don't have longitudinal data on patients, it's on registrars that we have that. So we'll look now a little bit about those aims I put up earlier. How well have we been able to meet these, and what do our findings mean? So were we able to open Simon's black box of what registrars see and look at the associations of those experiences? Well, this was one of the first analyses we did, and we've come back and revisited it a few times, but this was our initial look at it. And I'll just use this this graph. Now, this is not from the paper. This is actually from one of the practice reports we send out to our teaching practices. So ignore the blue columns, the registrars in your practice, and concentrate on the orange and green columns, which are, orange is our registrars, and green is comparing it to data that's been published from Beach on established GPs. And the things I'll just point out are cardiovascular disease, the cardiovascular chapter. First of all, our registrars see quite a bit less cardiovascular disease than do established GPs. They see a fair bit less endocrine, metabolic and nutritional disease. Read diabetes for that. And they see quite a bit of female genital problems, female reproductive problems, and quite a bit of pregnancy and contraception family planning compared to established GPs. They also see more respiratory disease, and when we drill down there, it's a lot of acute infections. So that's not particularly startling, but when you triangulate that with this data from the paper, and female registrars are the light grey, male registrars are the dark grey. And as you can see, female registrars, we always knew that they see more female reproductive health than male registrars, but it's quite staggering. They see 5 times as much female reproductive problems, and they see twice as much pregnancy and family planning, contraception, etc. So, and when you combine that with already our registrars see more female reproductive health and family planning, etc. It's pretty obvious that that there really is an issue there, and a lot of the time I think we come from the point of view of our male registrars, who we see as having a deficit in female reproductive health, for instance. Oftentimes male registrars won't get opportunity to be doing procedures even at the level of pap smears, etc., to the kind of experience we would like. But I think I'd like you to think about it the other way, that some of our female registrars are doing a great deal of female reproductive health work, pregnancy-associated problems, contraception and family planning, and that means they have to have relative deficits elsewhere. And I think that's potentially a problem, and the registrars may be quite comfortable. They may be quite comfortable doing that work, and people have sometimes make the argument that, well, they're going to be doing that once they're established GPs anyway. But the point is, the role of training is to give registrars a comprehensive education in being a GP, which is a holistic practitioner. And so this is a problem. And so what do you do about this as supervisors and as practices? Well, it's a little bit difficult, but I think you have to look at, do you have female registrars in your practice who do have this bias in their experience? And can you deal with that with appointments and scheduling, with even getting them some shared care with older patients and male patients? Again, you just have to think, what's the situation in your practice with your particular registrars and how you might deal with that. And I also want to just concentrate a little bit on chronic disease and older patient care and continuity of care. So we've looked at this, and we found that 30% of consultations the registrars include a chronic disease diagnosis or problem. That seems okay. And looking at, well, what are those things? Hypertension, depression, liver disorder, etc. That all seems pretty reasonable. But the only way to really get a handle on it is, again, to compare it with established GPs in Beach. And our 30% of registrars consultations compares with about 40% in Beach. So there's potential there for our registrars being having a lack of exposure to chronic disease care. Perhaps it's a pretty reasonable difference. There are some problems with actually defining chronic disease, which makes interpretation of that also a little bit fuzzy at the edges. But one thing we don't have trouble defining is patient's age. And so we also looked at older patient care, and we did analysis with our colleague Andrew Bonney from Wollongong. And what we found was that only about 18% of registrar consultations are with patients aged 65 or older. And established GPs in Beach, it's almost twice as much. So there really is a deficit in older patient care in registrars' experience. So when we looked at the associations, they're more likely to be chronic disease and more problems, which is expected. But what gave us pause for thought was older patient consultations for registrars were associated with less in-consultation information or advice seeking. And the consultations were briefer, where we really given the complexity of illness in older patients, we really would have expected both of those things to be greater in older patients. So again, that was cause for concern, and it made us worry, along with some other associations we found, that not only do registrars get limited exposure to older patients, but when they do, they may not be fully engaging with care of the patients. The concern is that when registrars see older patients, it's sort of in lieu of the patient seeing the supervisor or the other older GP, that they're putting on band-aids or just writing referrals or repeat scripts. And that's a concern because we need our registrars to learn how to manage older patients. So we also looked at continuity of care, and this is obviously important. It's a central pillar of general practice is continuity of care. So we looked at it in registrars, especially as we're concerned about their older patient and chronic disease exposure. And we found that over 40% of patients seen by registrars they had seen previously. So again, we have no benchmark for this, but it seems pretty good. And also, we looked at downstream interpersonal continuity. Did the registrar organise for follow-up with themselves to see the patient? And it was really, to us, seemed quite high. Again, we have no benchmark, but it certainly seems there that registrars are encouraging patients to come back and see them. And the thing that we found particularly sort of encouraging was that the registrars, for those patients who they were seeing, again, they're more likely to be generating learning goals. And so that made us think, well, they're making an effort to engage with that patient care. We also looked at interpersonal continuity, which is organising the follow-up with them themselves, and it's interpersonal continuity that the literature tells us is associated with better patient outcomes. And that's as opposed to informational continuity where the patient just sees another doctor in the practice. And we found that a big proportion of the registrars are getting back to see themselves, which was sort of encouraging. It was associated, again, not surprisingly, with the registrar working full-time and smaller practices, so that's just logistically easier, but also, again, generating learning goals and the consultations being complex. So that was a little bit of evidence which I suppose hedged our concerns around older patient care and chronic disease, but we're still left with this real concern about registrars not seeing enough older patients and not seeing enough older patient care. So it's a complex picture, but I think they were coherent themes that emerged. So what do we do about that? There's some concern there. So what do we do? So the first thing, I suppose, is that we had a number of meetings around in several places, interstate as well as in New South Wales, where we got supervisors together and had workshops, and where we presented this evidence and talked to them about their experiences, and basically workshopped, brainstormed ways that practices could increase the amount of older patient care that their registrars got. And there are And also our colleagues in Tasmania. Tasmania has been involved in ReCEnT since close to the start. And our colleagues down there also spoke to their supervisors, and their supervisors actually felt this was an issue. And so we did a qualitative study where we spoke to registrars and supervisors around this issue, the barriers and enablers. And putting it all together, it was very much that there were lots of potential ways to approach this, including formal shared care models where the registrar did most of the patient care, but under quite close supervision, including joint consultations where the registrar and supervisor occasionally would see the patient together. There were situations where some patients were registrar patients, where and at the end of a registrar term, there'd be a formal handover to the next registrar, and the patient would continue to be managed by the registrar. There were approaches to scheduling, appointments, a whole lot of things. But the big message was that these things had to be looked at and adapted to the particular patient populations, the way practices worked. They had to be adaptable to that particular practice. And then when we're just talking about the territory, that's just showing that before ReCEnT, we had no idea what registrars were actually doing. Now we're building up this body of evidence, so we're starting to know in some detail of what registrars are seeing. Again, that's just some more of the kind of things we've been looking at. We really feel we've got a bit of a handle now on what registrars are doing. So then we think about our other aim around what registrars do, and do their clinical behaviours align with evidence-based recommendations, benchmarks, etc. And again, what I'll concentrate on just a couple of things. We'll talk about things we've seen around antibiotic prescribing, because antibiotic stewardship is a big and increasingly important issue. So we've looked especially around respiratory tract infections and antibiotics, and this was driven initially by Anthea Dallas, who was a fabulous academic registrar we had from the north coast of New South Wales. And we've also looked at antibiotic stewardship in skin diseases, eye conditions, and we've also looked at delayed antibiotic prescribing. So with respiratory tract infections, what did we find? This was, again, fairly early on in the process when Anthea was first working with us. And we found that a bit over 20% of ERTs were treated with antibiotics. And for sore throats, bronchitis, otitis media, sinusitis, it was between 70 and 80%. And the first thing to say is that these figures are way above Australian and international benchmarks of what is reasonable, but they're significantly better than comparable Australian figures for established GPs. And this is something we'll talk about with other things. So with one lens on, our registrars are doing pretty well when we compare them with general practice, with wider practice, but it's still in excess of what the evidence tells us. So we looked at things that are prescribed, that are associated with prescribing antibiotics for those infections. And one was higher socioeconomic location of the practice, which was interesting. It's sort of a manifestation of the inverse care law. But we also found that if the registrar got advice or assistance from the supervisor, they're more likely to prescribe antibiotics. And at face value, this is a little bit concerning. One thing is that it may well be that the registrar will call in their supervisor for the patient who's more sick or they're more worried about. And so for sore throat or otitis media or sinusitis, being more unwell and sicker, it may well be reasonable to prescribe antibiotics. But our concern was around acute bronchitis and ERTs, where the evidence and the guidelines are not to prescribe antibiotics. Again, looking at some of the other prescribed we've looked at, benzodiazepines and Z drugs. Registrars prescribe a lot of benzodiazepines, more than you would think is indicated by evidence. But again, it seems to be less than established GPs. The same story with opioids for non-cancer chronic disease. a lot of opioids, but seemingly less than established GPs prescribe. And when we look at long-acting reversible contraception, LARC, where really the evidence is telling us we should be using LARC far more often, registrars prescribe LARC. It seems from our figures much more than established GPs. So we're getting this pattern of what registrars are doing in these complex, difficult areas, prescribing areas. Again, just to illustrate that we've done a lot of work around other things too, investigations, procedures, referrals of registrars. And again, a range of quite a lot of different things. So then we also want to see if registrars' behaviours change during training. And so we've looked at we've looked at some things, including benzodiazepine prescribing and antibiotic prescribing. You would hope, as registrars emerge from hospitals where they see a lot of very, very ill patients who have antibiotics given to them, and they emerge to general practice where most patients have self-limited infections, or benzodiazepines where short-term benzodiazepines in hospital may be reasonable. You'd hope that as they go from term 1 to term 2 to term 3, that their prescribing would decline. So what did we find? For antibiotics for respiratory infections, from going from term 1 to term 2 to term 3, there's absolutely no difference. It didn't decline. So that was a little bit disappointing for us. We also looked at benzodiazepines, and again, when we're looking within registrar, as an individual registrar went from term 1 to term 2 to term 2 to term 3, absolutely no decrease in benzodiazepine prescribing. But when we looked at the overall level of prescribing over time, as we went from 2010 to 2011, 2012, 13, 14, 15, there was a real decline in benzodiazepine prescribing, a decline of 6%, on average 6% per year. And that really is a lot. And then we've also now just completed analysis of some respiratory tract infections, so otitis media, sore throat, bronchitis, sinusitis. And again, we've found a similar thing. Even though individual registrars don't change from term 1 to term 2 to term 3, overall we're seeing quite impressive declines in the amount of antibiotics being prescribed. You know, really quite impressive. And we have to think, why is that? It's difficult. And so one thing, thinking about this a lot, is we think that what registrars do, is very much the environment they're within, the training environment they're within. And so probably we shouldn't be surprised that they are a bit closer to the current evidence and the current guidelines with a lot of their prescribing than generally GPs generally, because we would hope that training practices there is a higher adherence to evidence. We'd hope that training practices are in places of excellence, and we'd also hope that training practices have an uptake of over the past several years, increasing evidence around what we should be doing with benzodiazepines and opioids and antibiotics with prescribing. So that's how we interpret it, and it's really telling us about the importance of the training environment for what registrars do. So we also were interested in how registrars learn within consultations, and the main thing we looked at here was their help seeking, information seeking, assistance seeking, especially from their supervisors. And an early analysis, we found that they sought help from their supervisor in 7% for 7% of problems and 9% of consultations. And when we drilled down a little bit surprising perhaps to us was that it was more so for management than diagnosis. And that's something that, it's worth pondering on. But the big thing is that they call on your help quite a bit. And what do they call on your help for? no surprises. The most common ones, the most common disease chapters are skin and musculoskeletal medicine. No surprises there. Skin disease registrars come from hospitals where they've had often close to no experience with managing skin disease. Musculoskeletal disease, perhaps most of their experiences come on the end of a retractor at a hip replacement. So no surprising that the registrars seek their supervisor assistance for those things. And then we looked again at where in consultation information assistance was sought. And again, it's in 15% of problems or diagnoses, and 7% of problems or diagnoses they call on their supervisor or their supervisor's proxy. And the other main source of information was electronic sources. So not very often getting information from other specialists or from other health professionals, and not a real lot from hard copy sources. But what was really interesting is when we looked at the pattern of associations, it seemed clear to us that human information is preferentially sought for more complex problems. So we've got these registrars who are trained in the internet era, but when it gets complex, they go to the human sources, which is basically their supervisor. And that's not hard to understand why. They can get the facts from any book or any online source, but how to integrate that and integrate with the patient's presentation when things are a bit more complex, they need the supervisor. And again, this is from a registrar report this time, so ignore the registrar's data there and concentrate on the orange, purple and yellow, which is the overall registrar's aggregated data. And as you can see from term 1 to term 2 to term 3, there's a rapid fall off in the amount, in how much they're calling on their supervisor for assistance or advice, and not nearly as big a decline in electronic resources. Sure, it declines from term 1 to term 2 to term 3, but not nearly as dramatic. And presumably that means that registrars have been trained to be on the path of being independent practitioners and appropriately calling on their supervisor less. But some other work we say tells us that doesn't necessarily mean that they don't need a supervisor here. In fact, this may well be for the really more difficult, complex stuff. And I suspect that's been your individual experiences. So another way of looking at learning needs is to look at when registrars generate learning goals in their consultations. And so we also get registrars record when they generate a learning goal. Now, obviously, that doesn't tell us whether they actually went and followed that up, if they talked to their supervisor afterwards and followed up on that learning goal or went home and looked it up. But they did generate the learning goals, and it's in 22% of consultations. And the learning goals are associated with what you might expect with early registrar term, etc., with possibly more complex problems, but also it was associated with accessing in-consultation information. And to us, that was a little bit encouraging, because to us, it made us think, well, there's some trend here that registrars are not just using their supervisor to answer their question for them, to solve their problem. It's part of that wider learning process, and hopefully they're going home or talking further to their supervisor later to really consolidate and to learn more on that topic. And when I look at this result, I really think of some work that our GP colleague in Victoria, James Brown, has done around that in-consultation interactions between registrar and supervisor, and between registrar, supervisor and patient, and just how important a learning experience that is. It's not just about patient safety there. That is a really important learning experience. And we can look at this in terms of the disease chapters. So again, no surprises that skin and musculoskeletal medicine are the things that are most commonly learning goals are generated. But we also looked at it a different way. We looked at it as a sort of index of difficulty. So the darker grey columns are the proportion of times, if you see a problem, that you make a learning goal, as opposed to just the number of learning goals you're generating. So male genital conditions, registrars don't see them very often, but when they do, they frequently generate learning goals, a lot of learning goals. Similarly, they may not see a great deal of eye or ear, especially eye disease. They commonly generate learning goals. So what does this mean to you guys as supervisors? Well, I think what I would take out of that is that registrars, when they first start off, they have a lot of learning needs. And how do you prioritise those in your one-to-one protected time teaching? The stuff that's not the ad hoc generated by need at the time. So I suppose there are a whole lot of areas where you really need to spend a fair bit of time on, because registrars see a lot of it and they're not conversant with, so skin disease, musculoskeletal disease, etc. But you may also think that what role you might have in doing teaching around those areas that maybe are not very common but are really difficult when they arise. And maybe that's for further on into the registrar's experience after you've dealt with the more common problems in their first 6 months or whatever. So that's something just I think that you can think around when you're planning your registrar's teaching. So something else we looked at here, and this was work we did with Nancy Sturman, who's a GP and a PhD candidate in Brisbane. She's actually just about finished a PhD now, but she looked at whether registrars about firstly what they thought about help seeking during a consultation, the effect it had on patients' impressions of their competence. And a bit the registrars were concerned that if they sought help during a consultation, that the patients would think poorly of them. Now, what little evidence we have is that actually patients will think more of the competence if you're seeking evidence and help. And a quarter of registrars did have that impression, but 20% of registrars feeling uncomfortable about showing that weakness in front of patients is a concern, because as we talked about, and when I read this, I think of James's research on that in consultation education. It may be a barrier to registrars fully educationally gaining from those in consultation work with their supervisors. And Nancy also asked about how comfortable they were presenting inside or outside of the patient's hearing. And a majority of registrars are more comfortable presenting outside the patient's hearing. And as I said, thinking of James' work and other work as well, what a powerful learning environment that is, that triad of patient, supervisor, registrar. I think this could be a little bit of a barrier to that working. And I think what's the practical outcome? I think it's worthwhile you guys actually asking your registrars about this, talking about their levels of comfort, talking about how they feel about their impression when they ask for help in front of the patient, and perhaps reassuring them that this is patients value this and it's really valuable. So that comes down. We come to another issue. Can we change registrars' behaviours through education? And we've looked at this because ReCEnT provides us with data collection of what registrars do. We can compare what they do before our education compared to afterwards, and compared to those RTPs in the old days or RTOs now who haven't got that education session. And we've done that for test ordering, for antibiotic prescribing, for opioid prescribing, benzodiazepine prescribing. We've also looked at deprescribing. But we'll talk about opioids and antibiotics as our two exemplars here. So the CHAP study, in this now this was a pragmatic non-randomized trial. the reason is you can't do randomised trials in Australian GP training, vocational training, because it's not right with the culture. We want to give our registrars equivalent experience. So people are very wary of, we don't want to randomise registrars to things. But if one RTP or RTO has an intervention, we can compare it to other RTOs. And because in ReCEnT we collect, as I showed earlier, we collect so many variables, it makes this quite a robust, they may not be randomised, but it's quite robust because we're able to adjust statistically to give findings that are credible. And so in this, we constructed online modules based on the best current evidence, but delivering some of the evidence, but mainly concentrating on communication skills and how to take the patient with you on that journey to the right outcome, which often is not antibiotics. The science of this is just so straightforward. We've got umpteen Cochrane reviews, we've got other researchers all over the place, but it's some of the easiest decisions you would make in your daily practice. But the art of medicine here can be really quite complex in dealing with patient expectations, a whole lot of issues, and we spent a fair bit of time in this intervention working on that. It was followed by a face-to-face education session, which reinforced that. We also provided supervisors with outlines of an educational session they could have one-on-one with their registrar in the practice. And the thing is, we delivered the intervention to both the registrars and their supervisors separately, but the same intervention. So what did it work? Well, we had no significant reduction in prescribed Verdes, but that was because, as we talked about earlier, that the rate of prescribed Verdes had dropped off so much that you couldn't improve it. But for bronchitis, bronchiolitis, we did get a significant reduction in prescribing, and it was a big reduction. It was 16%, an absolute reduction of 16%, which is about as big as any educational intervention for antibiotics prescribing anywhere in the world has got, and a great deal more than a lot of them. We might just skip over that for the moment. But then we did a similar intervention for opioid, and again we just had a brilliant education session with real sort of experts in the area who produced a really fine session. And did we change opioid prescribing? Well, not a jot. We didn't change it at all. We may have actually made an impression on initiation of opioids, but the trial was probably but it wasn't statistically significant. We're probably underpowered for that outcome. But we also, at the same time, did a before and after evaluation where registrars questionnaire-based, paper-based clinical vignettes, and they gave their answer to what they would do. And we got a change from before the intervention to afterwards. So registrars' knowledge and anticipated clinical behaviours changed and improved pre to post significantly. So we changed registrars' knowledge and we changed their anticipated actions, but we didn't change their actual behaviour. Now, why might that be? Why could we do it with antibiotics but not opioids? Well, opioids are a harder nut to crack for a whole lot of reasons, and we accept that. But one thing that worried us is for logistic reasons, we weren't able to deliver that educational intervention to supervisors at the same time. It only went to the registrars, and we couldn't help just feeling we'd missed a trick there. And if we had been able to have the education together, we could have had the registrars and supervisors working together to formulate plans within their practice to be able to reduce the amount of opioid prescribing. So that's our overall impression. So that overall impression is that education is really good at changing knowledge, but in and of itself, it's not enough to change behaviour. So education is really important, but it's It's necessary but not sufficient. To change behaviour in the clinical context we're concerned about, you need to have these other factors. Now, this is behaviour change theory. This is Mickey's behaviour change wheel. So as well as education and appropriate training, you need other things. You need modelling, and this is what we're talking about when we saw those registrars practice being a fair bit better than non-training practice GPs' behaviour. When we looked at the change over time, we think that the clinical environment where registrars work is what determines their clinical behaviours. So if they see you guys practicing evidence-based medicine, they'll practice evidence-based medicine. Environmental restructuring. So, you know, even little things like having posters around the practice around educating patients about antibiotic use for respiratory tract infections, or opioids for chronic pain, benzodiazepines for sleep, and environmental restructuring by perhaps having practice policies for common presentations that can sometimes be difficult, like antibiotic prescribing, like opioid prescribing for pain. So we think that this is where we can really make a difference to our registrars' training. We sort of don't want to go over this way to coercion, but we certainly think, as well as our education and training, we need enablement with licensing registrars to go with the evidence, role modelling from their seniors, their respected peers, and environmental restructuring.
Thanks, Parker. I just had one question before we launch into some of the observations that have been made. To what degree does the ReCEnT replace the functionality of what Beach monitored in terms of patient encounters?
So when we were setting this up, Simon and I looked at models from other places, especially the ambulatory care study from the US, which is still going. It's been going for a long, long time. And we looked at Beach, and there were one or two others we looked at. And there was a commonality amongst all of those. And essentially we picked out the stuff that we wanted, but we tried to make it where possible. We tried to make it pretty much comparable with Beach so that we could compare our registrars with what established GPs are doing. And you can see that that's useful there when we're trying to get a handle on where do our registrars sit to compare it to Beach. And the Beach data now, unfortunately, Beach is not going. And so we still think that the data from the last rounds of Beach is comparable. We still use it, but we sort of miss Beach.
Yeah, definitely.
Does that sort of answer the question?
Yeah, no, absolutely. There was a question here about patients seeking out continuity of care based on complexity, and an observation that perhaps shared care between a registrar and a supervisor might be an appropriate strategy. Was that something that the aged care project in Tasmania looked at, a shared care type approach?
Yeah, that certainly came out of those workshops we did with supervisors, and it certainly came out in that qualitative study that a shared care model, and there are a whole lot of really quite nuanced ways that the supervisors felt it could work, and I suppose it depends on your own practice. But yeah, having the registrar do the bulk of the work and the learning, but to reassure the patient and also to reassure the registrar to have pretty tight supervisor oversight. And the idea of having the occasional joint consultation was certainly thought to be potentially valuable there.
Yeah. Taris from RVTS has said some of the work that they've done regarding what advice registrars sought from supervisors showed that 17% of discussions were medico-legal in nature. Did you identify any discussions regarding work cover, insurance, medicals, etc., as part of the ReCEnT study?
No, that's interesting. Certainly, again, what we have with the help seeking and assistance is it's linked to the problems. Again, I wonder just how comparable these are, because ours are in consultation, actually inside the consultation advice, whereas I suspect medical legal stuff, it might be more often talking to the boss afterwards. I'm not quite sure. But certainly that's not something we saw in our data. And our data is linked to a problem, but it doesn't say that it's, so we only asked them, was it related to diagnosis or management? We obviously didn't have an option of medical legal. So that's an interesting thought.
Yeah, definitely. We've got an observation here and I guess a subsequent question by Jan that's been posed, and that's excluding nursing home visits would by definition exclude complex aged care questions. Would it not be good to have registrars actively involved in nursing home visits? Does ReCEnT capture nursing home care?
No, it doesn't capture nursing home care, and that was for pragmatic reasons. Just the difficulty of we're worried about registrars losing their pads at the nursing homes and home visits, etc. And now with online, I understand South Australian registrars have an app on their phones so they can do it at nursing homes, and that would be really something that we'd like to investigate later if we sort of have the opportunity. But we don't do it. We don't do it now. What we have done is we've looked at registrars just answering on the questionnaires they do as part of ReCEnT. Do they contribute to the practice after hours roster? And we've found a lot of interesting stuff there, and also related to studies we've done of alumni and looking at whether they do after hours care. And one of the things we found is that there's a strong association between doing after hours care when you're a registrar and then doing it when you're 6 months to 2 years post fellowship. So I think there are myriad reasons why it's good for registrars to do after hours care during their training, because it's good for their education. But also there's some evidence that it may contribute to workforce later, because they're more likely to do after hours care when they're fellowed.
Yeah, interesting. There's an interesting observation here that poor confidence may merely be part of the development of mastery. But directly preceding that is a really interesting question, and that is, are learning goals related to how poorly topics are taught to undergraduates? Do you collect any data of whether these registrars have completed their undergraduate training?
We didn't initially, but then at the request of someone halfway through, so for several years, we have been collecting where their undergraduate degree was. We've been collecting that data, but we haven't really thought, because people wanted us to do it, but we haven't actually used it yet. So maybe looking at that compared to learning goals, maybe there's a research question there if you could tease it all out. But yeah, I think the learning goals, I think to some degree, reflect lack of adequate preparation. And I didn't have time. I had a slide there to talk about a paper that Susan Wern and Neil Spike and I published, which was really 3 old and cranky GPs partly using recent data, but a lot of it was our own sort of crankiness and anecdotal, that we just feel that registrars are coming into GP training with lesser experience and expertise than in previous years, and as a result of structural changes in hospital work. And some of those changes in hospital work are for good reason, but they have the unintended effect of reducing registrars' exposure to a whole lot of disease scripts, and also probably taking less responsibility for patients' care. And then they get under general practice where they've got this really just everything. That they have to deal with everything, and we think they're less prepared for that than previous years because of structural changes in hospitals. And what we're really concerned about that is that then RTOs and especially supervisors are being required to fill that gap and fill the gap of basic knowledge where they should be concentrating on more difficult areas, the real art of medicine and the synthesis of evidence and putting it all together rather than just teaching the basics. It should be about putting the basics together because it's hard in general practice. And our concern is that our supervisors and RTOs are devoting educational time to really basic stuff rather than that more value added. But again, we're three cranky old GPs.
I heard you say a couple of times in the presentation that the registrar prescribing rates were still lower than fellows. But so we've got a really interesting question here about the correlation between the patterns of registrars' prescribing patterns and whether or not they correlated with their supervisors. Is the role modelling rubbing off, and have you looked at that?
Well, we can't because we don't have the data on supervisor. These are what I'm saying there is when we've looked at everything all together and put it together with our experience, what we think is happening, and we're pretty confident that it's really the supervisors are where we really need to be concentrating on supporting their practice, but also ways in which they can teach registrars. So, for instance, if any of the supervisors from New South Wales or ACT, I urge you to, in about a month's time, where we have revamped that antibiotic prescribing educational package, and it'll be being offered to the supervisors as well as the registrars. So there's stuff in there about the art of taking patients with you with consultation techniques, and that's the kind of thing I think supervisors can be helping the registrars with. And our qualitative research has really told us that registrars report that in prescribing antibiotics, that supervisors, really knowledgeable supervisors, have, it's very simple to tell a registrar, no, the Cochrane review says don't prescribe antibiotics there. But what they valued was the registrar, the supervisor saying, yes, well, what you do here is you need to approach it with the patient this way. And, no amount of telling them that antibiotics don't work, just say no, it doesn't help you. You need supervisors to guide registrars through the process. It can be, we all know it can be difficult.
Yeah, absolutely. The modelling of asking for a second opinion from a colleague was an interesting point that cropped up in the presentation. And is that something that has led to other actions within GP Synergy or any of the other RTOs?
We don't. Yeah, that's an interesting thing. We don't have data on that. But again, I think it's pretty obvious. Again, if you accept our premise from our data that it's the practice environment that determines what registrars do, as opposed to what registrars know.
Yeah.
And I think from that you'd say, well, if we have supervisors modelling that, I don't know the answer to everything, I'll look that up, or better still, get the registrar to look it up for them, or they go and get a second opinion from a trusted colleague. I think that's modelling, and I think you'd have to think that that's part of the practice environment. People do seek help from their colleagues, because remember we're trying to train registrars for when they're out there without their supervisor. But just because they haven't got their supervisor doesn't mean they don't have sort of supports to go to for advice.
Yeah, absolutely. Srishti's asked, should there then be more emphasis on communication skills in GP training then? What's your take? Do you think that there's enough? Again, my experiences in one RTP and one particular RTO, especially RTP, and I think that's quite good communication training. But it was interesting with the antibiotic educational package, where we used a lot of stuff, and we collaborated with Paul Little from Southampton, and there was quite a bit there on communication techniques. And when I first saw the films, I thought, yeah, these are good, but maybe our registrars are going to say, what do we know this stuff already, because they do get quite a bit of communication skills. But the feedback we got, we did the qualitative study just
plus the anecdotal feedback that people gave us, was the registrars thought it was great because it was really applying those fairly generic consultation skills, but to a particular problem, and one which they saw all the time. And a lot of them, our other qualitative work told us, that often created cognitive dissonance and distress in registrars, feeling that they had to prescribe when they knew that that wasn't the best thing for the patient. They thought it was, the feedback we got was just terrific, that they had this very specific application of the generic consultation techniques.
Scripts. Yeah, absolutely. Well, listen, thanks very much, Parker, for making yourself available tonight. That was really interesting. I think it's likely to be really useful for all of the supervisors participating tonight. So thank you very much. Now, as always, we'd like to acknowledge the funding that GPSA receives from the Australian Government under the Australian General Practice Training Program. Without them, we couldn't be providing this content to you. So thanks very much for joining us, and good night. Thanks, Parker.
And thank you, everyone.